And yeah, I'm really flattered now. All right, so we had a good talk by Dr. Huda about the speech and speech language delay in children with neurodevelopmental delays. So that was from a physician's point of view. So my talk is mostly from a speech therapist point of view. So how do we do an intervention for such patients? So as a physician, you would do an assessment, you would diagnose if the child has cerebral palsy, any other specific diagnoses that have to be made. Now, when they come to us, most of the thing that's being asked, be it physicians, be it family or caregivers, can they talk? Will they start talking anytime? Now that's most, not just cerebral palsy, any child who comes with a developmental delay. The first question that everybody asks is, can they talk? Please make my child talk. So I've been in the field for 20 odd years, and this question arises almost every day to me. So what am I going to talk to you about is a little look into what speech language development in children with cerebral palsy will be. It just gives a lot of numbers and percentages, which is all an average. There's different study gives different numbers. And then a little bit into what do parents think when they come for speech therapy. And what do we do? The next one would be, what do we do as our part of our intervention? That would be a speech assessment. It could be the language assessment. I will talk to you about it. And what are the different therapy options? And the last point would be the alternative and augmentative communication, which is quite in practice nowadays for children who have severe speech language delay. So as I said, I think Dr. Huda did mention about the numbers, about the lesions, etc. But just a brief preview into all of that. So what is usually mentioned is, in many of the studies that have been mentioned, is lesions in cortical or subcortical regions and the basal ganglia. There's the more severe the lesion, the more severity would be in their communication skill. There would be poorer outcomes in communication. And it is predicted by the symbolic behavior, speech and gross motor function at 18 to 24 months. I think there's a problem with my slide. A little bit has gone outside. I'm sorry about that. And usually what they say is, if the child does show communication skills, some form of communication skills, by the time they're 18 to 24 months of age, there is a better predictability about their communication skills. There would be a better improvement in their communication skills. So established talkers at 2 years of age are likely to have age-appropriate approaching, or at least an age-appropriate receptive or expressive language by the time they're 4 years of age. So that is what we look into. So by the time the child is reaching 2 years of age, as a speech therapist, what are the skills that I see in the child? And based on that, I could give an approximate prediction that, yes, this child would be a better talker or not. Of course, it's not written on rock or anything, but it could definitely change. And if we see there are no spoken words at 2 years of age, there's a likelihood that the child would not be speaking. They would mostly be non-verbal communicators. We'll come into all of that later. And the severity of the functional motor limitations together with the intelligence factor will give us an idea about their language and motor speech problems. And severity of functional motor limitations together with your communication will tell us if this child is going to talk. Because at the end of the day, is this child going to talk? That is what matters for the parents or the caregivers. Now, children whose communication is causing a concern at 2 years of age. Demographic characteristics, early medical history, type and distribution of cerebral palsy, and functional performance measures predict the severity of speech and communication difficulty by 4 to 5 years of age. And 55% of children with cerebral palsy have difficulties engaging in face-to-face conversation or communication. 21 to 36% have dysarthria, 19 to 32% are unable to speak at all. So you hear all these words flying around: dysarthria, praxia, aphasia. So this is all related to the motor communication skills of the child. Now, dysarthria, we would come into all of that as and when we go forward with the presentation. Now, what do parents expect? So we have all three presentations from parents. The most important is the ones who are properly educated. They know what this child is. They know which way this child is going. Are they going to communicate? Are they going to walk? What is their future in terms of communication? Now, they are easy to be handled with because they would have been properly guided. They have read a lot. They have researched a lot about their child, and they come to us saying, we know this is what my child is. We want your support in helping this child develop in his communication in whichever way is possible. There's no expectation that we want him to talk or we have no hope with this child. And there's this group of parents who have absolutely no hope. They're like, oh, my child is bedridden. He's in the wheelchair. We have no hope that he's going to communicate. So they don't even come for therapy. They don't even give a chance for the child to start any kind of mode of communication. So there we lose out on his skills. Maybe this child does have some form of skill where at least he can communicate his basic needs. No, the parents have absolutely no hope. So now these are all based on my experience in the clinic, where I have, for example, when we say no hope or no cure, I've recently had a patient, she's 6 years old, cerebral palsy, she's got microcephaly, etc., where I am doing communication and dysphagia therapy. She's got a PEG tube. She doesn't have any form of communication other than laughing and smiling or crying, where the mother decided that she does not want to come for therapy 2 to 3 times a week because, oh, she's not going to show any kind of improvement. And she comes only once a week. And therapy once a week is, of course, better than nothing, but definitely not enough for this child, because when she comes to me, even that once a week, I can see that if this child got better or more number of sessions with me, definitely there's going to be some at least basic communication where she can at least choose what she wants and say no to what she wants. And then there are these parents who have really high expectations. Again, just last week, I had this father who came and said, oh, inshallah, in 2 to 3 years, my child is going to start talking, where in my mind, I'm not going to say no, but at least I know we may not reach the father's expectations where he's even expecting this child is going to go to a normal school. So this is this wide spectrum of parents that we have to deal with. That's the barrier that we have to cross first and then start with our therapy or even our assessment. So now what do we do as a speech therapist? What is the assessment that we do? So what are we looking at? It's an assessment at 2 years of age. Of course, we have to deal with early intervention, but most of the time the patient is sent to us when the child is 2 years or more. So we're looking at what is their current nonverbal cognition. Can they understand anything? Do they identify family? Do they have stranger fear? Do they understand this is a hospital? I'm not comfortable in this situation. Or are they just happy with any kind of situation that they don't have an understanding of where they are? They don't recognize family members, like any person next to him is okay for him. And then we look at the speech sound system. Are they making any sounds? Are they making any words? What is the current status at which they are making sounds or words? And as these early skills can predict communication at 5 years and could give us a guidance to the intervention and include decisions around the most suitable type of AAC to supplement or replace speech. So again, I will be talking about what AAC is, because by the time they're 2, we get an idea how their speech is going to be by the time they're 5 years of age, and we can counsel the parents about the different other alternate methods of communication if not the child is going to talk. Now, communication function classification system is one of the common assessment tools that we may use, which focuses on the activity and participation in everyday life and classifies the children's ability to communicate with familiar and unfamiliar partners, as what I discussed before. Is there a differentiation in their communication when they're familiar with their parents or caregivers, or when they come to us as speech therapists in the hospital with the doctors? Do they differentiate the situation? What is their communication ability at that level? And it's evaluated at 5 levels, that is ranging from severe to normal. Those are the 5 levels. And the information about the communication methods are provided using the categories of speech. So now then the question is, what is the difference between speech and language? So now to a layman, how would I explain that? Speech is how you talk. Language is what you talk. So speech is the rate at which I talk, my voice, my articulation. All of that is how I talk. Whereas language is what I talk, the content in my speech, the words that I use, the sentences that I form. Now that's language. So here we are looking at the speech. Is the child able to make sounds? Are they articulating different alphabets? Are they making words? So that is speech. Now, are they using any unaided AAC? I will talk to you about it. Are they using sounds to communicate? Are they using eye gaze to communicate? Are they using gestures to communicate? Are they using pointing, or are they following any sign language to communicate? So these are things that we would look at under unaided AAC. Now, aided AAC is such as communication books, boards, pictures, or there can be high-tech AAC or low-tech AAC. A low-tech AAC would be picture boards, alphabet boards that they would use. High-tech would be where there's more mechanized, where there's communication used using an iPad or a communication speech generating device. So these are all that we would look at. So based on these 3 to 5 categories, we would assess the patient and we would give them a score and then identify which way our therapy is going to go. So as I said, can they vocalize meaningfully? Can they make these vocalizations into meaningful situations? If at all they talk, is their speech intelligible? Are they forming words? Do they have unclear speech? Now that's dysarthria. Dysarthria is when the speech is slurred in a layman's term, that is dysarthria. Apraxia is when the child knows what he wants to say, but he's not able to produce it. That's more in a way that you can understand. What is the difference between dysarthria and apraxia? Dysarthria is they know what they want to say and they are able to say it, but it's not clear. Apraxia is they know what they want to say, but they're not able to program it and present it. It just doesn't come out. That's apraxia of speech. And what is their voice quality? Because in children with cerebral palsy, definitely the respiratory system affects the phonation and thus the production of speech and thus their voice. So definitely what their voice quality is important for us. So language assessment, as I said in summary, is whether they're verbal, are they talking, or non-verbal, are they using signs, gestures, or communication boards? What is their receptive language skills? What are their expressive language skills? What is their current status in terms of understanding? What's their current status in terms of talking or expressing themselves? Now, speech and language therapy, what is our main goal? Is to maximize the communication abilities. What is the ability that they have now? How can we push it forward and shape it into a better communication and use it into a functional status? And conventional therapy techniques, which are focusing mostly on the child, and we look at early intervention starting right from the time that the child has been identified to be having a delay in their development. Then the conventional therapy techniques would be the oral motor exercises where we work on the muscles of the mouth and try to strengthen the muscles to improve the speech production. Phonetic placement techniques about the articulation. If they are not able to say a specific alphabet properly, then we work on the phonetic placement of the tongue, the jaws, the teeth, the back of the throat, etc. LSVT, that's the Lieselman voice therapy loud technique, where we are focusing on the voice. Hanon program, prompt program, electropalatography. These are all some of the more specific techniques that we used, and I will go into some of them. Now, early intervention, this is coming into a research and evidence-based practice a lot nowadays, where we are focusing more on the parents and their interaction with the infants rather than the parents bringing the child to the speech therapist and we focus only on the child, where we enhance the parent sensitivity to their own hospitalized preterm infants and to encourage them to use well-researched stimulation activities. So we are trying to recognize and support individual infant needs and to initiate positive stimulation, such as using activities such as massage and kangaroo care, where the mother, let's say, because we're talking mostly in terms of the mother, and of course the father also, where their interaction with the child starts from the time that the child has been identified with the delay and the child is in the hospital, and we don't wait till they go home and then we start therapy with the speech therapist. So this was basically making an emotional connection between the parents and the child, where the parents identify even a single move from the child is a form of communication towards them to tell them that their child is happy, unhappy, they want something. And the better outcomes at 3 to 6 months in terms of mother-infant interaction and the infant self-regulation and temperamental characteristics and parenting stress. In addition, early indicators of developmental outcome would favor at 24 months and enable the parents to appreciate their infant's unique characteristics, temperament, and developmental potential, gradually sensitizing the parents to infant cues, thereby improving the interaction between the parents and the infants, which I just told you. And again, it's a mother-infant training program. Now, that's a more specific training program. There's different forms of training programs for the early intervention. Now, this mother-infant training program is something that we have identified to be very good with the child. So the parent is the therapist, not the speech therapist. We guide the parent as to how to deal with the child right from the time the child is in the hospital. And it aims at reducing the infant stress and the parent stress and aids in development. And here we provide seven one-to-one sessions conducted in the week before hospital discharge and 4 home visits within the next 3 months. Of course, the home visits don't always happen, but at least the prior to hospital discharge sessions do definitely happen. And parental sensitivity training sessions are covered for the infant's homeostatic, motoric distress, and alert behaviors, repertoires of playing behaviors, caretaking routines, and temperament. These sessions were designed to enhance the quality of mother-infant interaction by teaching the mother of low birth weight infants to be more sensitive and responsive to their baby's physiological and social cues. So communication starts right from day one with the child with developmental delay. So other specific programs, as I mentioned, was the Hanen program. It takes 2 to talk. Here again, the concentration is on the parents and the child, where the communication is not just from the child's point of view, it's between 2 people. Now, communication happens when I am talking to a person and they respond, and then we take the communication forward. We take the conversation forward. So here it's for the parents of young children from birth to 5 years of age who have been identified as having a language delay. Now, this is not specific to cerebral palsy, but it does work with children with cerebral palsy. And it's in a small group, personalized group setting. Parents learn practical strategies to help their child learn language naturally throughout their day together. And OWL, to let your child lead, that you observe, wait and listen. And this was spoken about in Dr. Huda's speech also, where we let the child lead your communication. You follow their leads and you converse based on what the child wants to tell you. If you recognize the child's stage and style of communication so that we can identify the next steps and goals, identify what motivates the child to communicate, use the strategy, follow the child's lead to build their confidence and encourage them to communicate with you. You follow the child's lead and you communicate on what they want to talk about and not what you want to talk about, because that gives them more confidence in communicating about something that they like to talk about. And adjust everyday routines to help the child to take turns back and forth in interactions, follow the child's lead to build his confidence and encourage him to communicate, to talk to the child in ways that help them understand language and use them when they are ready, and use strategies when you play and read books with the child to help them interact and learn language. So it's a lot of activities in small groups rather than identifying the child and putting them in bigger groups where we lose the child in the big group of communication. LSVT, something that I did mention before, we're working on the voice quality. So basically, we're talking about children who have some form of communication, verbal expression, but their phonatory system does not support them with their communication. So we help them improve their voice quality, thus improving their speech production. I don't want to go further in detail into that because it's more speech specific. Now, AAC, that's something that needs awareness amongst professionals as well as caregivers, because when they come to us and say, I want my child to talk, they also need to know, yes, we will try to get your child to talk. But to start with, how is the child going to talk right now at this moment? If they can't talk, what do we do? For example, I'm not able to talk today. I've been asked to keep quiet because I have a voice problem. How do I communicate? Through sign language, through writing. So it's an augmentative or alternative form of communication. If the child is not able to talk, as we mentioned, if we predict this child is not going to talk, then we need to find another mode of communication for this child to maximize their potential and lead for a higher quality of life possible. So we have unaided and aided. Unaided is where we do not use any kind of technology. It can be sign language, gestures, facial expressions, writing, drawing, eye blinking, even just blinking their eyes to yes or no is a form of communication. Aided, where technology is being used, where it can be high-tech or low-tech. Low-tech would be basic communication boards with pictures or words or alphabets. High-tech would be using anything as simple as iPad or computers, or we have speech-generating devices. Now, those are some low-tech options that we have that are being used. If you see the picture at the bottom with the child, it can be just a simple button where they press when they want something. They are not able to say anything else. They would just hit it. If the parents say, do you want something? He would hit that to say yes. He wouldn't hit it if it's a no. Or if he wants to gain someone's attention, he would bang that and it would make a noise. And that's the lowest form of a low-tech option. on the top, you would see pictures. There's a picture board where with the most important communication details would be put in there, and the child chooses from that. Or you see the speech therapist sitting with an ABCD communication board where the child would either point to the alphabets and make a word, or they even use their eyesight, and we have to select it, and they would be able to say yes or no, and then we form words. So those are some low-tech options. Now, speech generating devices. So there's a lot in the market nowadays. Previously, when I started 20 years ago, there were just like 1 or 2 companies that had low-tech, speech generating high-tech devices. But now there's so many companies that even I'm not aware of where they use pictures or even alphabets or even words, because children reach an age where they can start reading, they can start identifying words, and they put words together to make sentences. So if you see there, or the picture on your other side where the child is with a board, where it's mounted onto their special wheelchair, and they go around with that and they can communicate in any situation. So it's an MDT approach, of course. I need the support of the physiotherapist or an occupational therapist, because we need to mount it. We need to identify which way the child can talk. We need to identify the mobility skills of the child. Are we going to depend on his eye gaze? Can he move his hands and legs? Or he might be able to only move his fingers and he can point to things. Or is he able to move his head and then move his head right and left and then identify pictures or identify the words from the communication board? So we need the support of an MDT, of multidisciplinary team. And we check the current wheelchair. Is he using a wheelchair? Can we mount an AAC board on the wheelchair? Has he had a previous experience with AAC? Can we further develop onto that and make it something a little more advanced based on his communication skills? And what environment is he going to use it on? Is it in the home, school, or does he go outside to social gatherings? Does he need to use it in such situations? Or what is the current mode of communication? He's using only sign language. Can we shift that to a low-tech or a high-tech mode? So these are all the different options that we need to consider. So I think we need to give a little more awareness amongst the caregivers, amongst professionals, that if not talking, there's always another mode of communication, which we need to identify, so that, we basically help in the functional communication for the child, improving their quality of life. Thank you.